Kinda.
Yes. Hi, Dr. Shervin.
Hi. Um, let's see. Would you like to get started, or do you think I should introduce you because somebody here doesn't know who you are?
Um, yeah, it doesn't matter. I wasn't sure if more people were coming or if I should wait a little bit longer. Um,
Let's see. We're missing some fellows. Okay. Well, now that Steve and Josh are
okay. I mean, I don't mind waiting a little bit longer. I'm not sure if I will take up the whole hour.
Even
for-
Josh is here.
here. Yeah, my advice would be to go ahead and get started.
Oops.
And
Okay.
Sorry, why you not muted? Sorry.
all right, everybody who should be muted, please mute. And Dr. Kakinda is what as hopefully everybody knows is one of our current and soon to be ex sleep medicine fellows who is doing her grand rounds presentation today. So thank you.
Thank you so much, Dr. Shervin, for that introduction. So today I'm going to be talking to you guys about sleep health inequalities, specifically health implications of sleep deserts. So I initially became interested in this topic, likely due to my internal medicine training. I actually did my residency in a more rural, underserved community in central Georgia. And so I did learn a lot about certain health inequalities in that patient population. And I also feel like this is a very important topic because oftentimes a lot of these health inequalities are not talked about as frequently. And so it is important to understand kind of where your patient may be coming from and how it might impact their sleep health. So before we get started, I did want to give a little bit of some background review on specifically sleep insufficiency. All right, so with sleep insufficiency is when an individual is persistently failing to get the adequate amount of hours of sleep to maintain normal levels of alertness or wakefulness. The American Academy of Sleep Medicine, as well as the Sleep Research Society, came to a consensus and put out some recommended minimum sleep requirements per age group. So I have included it here on this slide. Now, for children 6 through 12, recommend minimum at least 9 hours and or more. Now, I didn't include younger children as I mainly focused more on adult patients on this presentation. However, I feel like pediatric sleep inequality is equally as important and definitely deserves its own presentation. But just for the purposes of today's Grand Round lecture, I kind of wanted to keep it within the adult population. And even then, there's still a lot of information on sleep inequalities that I wasn't able to include on this presentation today. But know that children less than 6-year-old and even infants, they all have varying sleep requirements depending on their age. But for this, so children 6 through 12, greater than 9 hours, and then adolescents are recommending at least 8 hours, and then for adults, minimum is 7 hours of sleep per night. I included a little, it's really a screenshot of the diagnostic criteria for insufficient sleep syndrome per the ICSD-3-TR. And so one of the main features is that these patients have to have an irrepressible need to sleep or have some daytime lapses into sleep. And when making this diagnosis, we do have to characterize how much sleep is the patient getting. And that can be either through history, it could be through collateral information from family members or loved ones. You can also obtain this through sleep logs or actigraphy. And so when getting how many hours of sleep, oftentimes it has to be shorter than what the recommended sleep is for that age group. There also has to be some curtailed sleep patterns that are present on most days and has to be at least for 3 months. And usually these curtailed sleep times are usually restricted by the patient either by using an alarm clock or having somebody else kind of wake them up. And so what we often see is that when there are days off or on weekends, these patients tend to try to catch up on their sleep, and so may sleep for longer hours on these weekend periods. A key feature in this is that the sleepiness cannot or shouldn't be explained by other untreated sleep disorders or other medical comorbidities that might better explain the sleepiness. We do also have to consider if medications or drugs as possible side effects that could be causing sleepiness. And most important is that oftentimes, if it is insufficient sleep, once they start getting the recommended hours of sleep, that sleepiness typically resolves. There's a lot of research out there on the health implications of not getting enough sleep. There have been several studies that show that sleep deprivation can impact neurocognition as well as mood, executive function, and cognitive performance. It has been also shown to disrupt some hippocampal function, particularly with memory consolidation. And we can even see a lot of these neurocognitive deficits occurring in scenarios of sleep deprivation that's associated with sleep fragmentation due to underlying conditions. Some neuropsychological symptoms of sleep deprivation include these mood changes. People can get more irritable. They may have more fatigue, low energy, decreased motivation and coordination, easily be distracted. And so there's also safety concerns as well when it comes to insufficient sleep and having a lot of daytime sleepiness, especially when it comes to those who are driving motor vehicles. It does increase a risk of having more accidents. And so it is important to treat this. Insufficient sleep as well has been shown to have cardiovascular impacts. Chronic sleep deprivation has been associated with hypertension, and there was a sleep heart health study that reported that insomnia and poor sleep, as evidenced by less than 6 hours of sleep on PSG, has been associated with an increased risk of cardiovascular disease. There was also another meta-analysis that showed that short and even long sleep duration has been associated with an increased risk of all-cause mortality, cardiovascular disease, coronary artery disease, and stroke. What this meta-analysis also alluded to was that the lowest risk was noted to be around 7 hours of sleep, which is what currently the recommended guidelines for adults is at least minimum of 7 hours. So even just having that 1 hour reduction of sleep compared to having 7 hours per day has been associated with a 6% increase in all-cause mortalities. Not getting enough hours of sleep per night has also been shown to impact metabolism. So having chronic sleep restriction can be associated with metabolic syndrome as well as type 2 diabetes. It has been shown to disrupt metabolism by altering certain gene expressions of and some hormones that are involved in metabolism and can predispose to obesity. Interestingly enough, fragmented sleep as well as poor sleep efficiency and then an increased wake after sleep onset has also been associated with risks of obesity. And this is, I included just a little bit of review really for all of us, but for the fellows as well, as I'm sure this might be tested on the sleep boards. But when you have chronic sleep restriction, it has been associated with increased cortisol levels as well as increasing ghrelin levels and decrease in leptin levels, and overall kind of increasing in your appetite. And so when you're awake for longer periods of time during the day, your body does need to compensate for those additional energy needs that is required to maintain wakefulness. And so oftentimes that may lead to an increase in caloric intake. Oftentimes individuals who are sleep deprived may reach for certain unhealthy foods or junk foods or things that are high in calories in order to kind of help with the increase in energy needs. But so oops. Okay, so I did mention a little bit on this earlier, but having a restricted amount of hours of sleep has been associated with behaviors. It's been associated with depression as well as anxiety and even sometimes irritability and aggression. It can also increase risk of impulsive behaviors, and even on the more extreme end, can subsequently increase risks of unplanned suicides. And so by improving your overall sleep and sleep quality has been shown to improve mental health. Even so much so, like there was a dose response relationship between sleep quality and mental health improvement. So our current clinical recommendations on how to improve sleep health right now is really to establish that regular sleep-wake schedule. You want to reduce any stressors or exposures to certain blue lights around the hours of sleep. And of course, you want to limit using the bedroom for other activities that are not for sleep or for intimacy. And of course, substances such as alcohol and nicotine and caffeine or certain drugs and stimulants, you would want to avoid these these substances that might disrupt your sleep. And so patients should be counseled on these behaviors and lifestyle and try to modify accordingly to help optimize sleep hygiene. And so this brings me to my next point when it comes to sleep deserts. So what if the patient is living in a certain environment or has external stressors that are outside of their control that might impact their ability to have good sleep? And so, what are sleep deserts? So, sleep desert is really a term that refers to like neighborhoods or living conditions that are just not conducive to adequate sleep health. And this concept can even be broadened to include other scenarios, such as, like, for example, it would be like college students or hospitals. And the term sleep insecurity has been kind of used to kind of include more individuals that might be impacted by their environment. So I really wanted to emphasize that there is clear evidence of economically disadvantaged neighborhoods that have poor sleep health and overall just poor health in general. There is a lot of there may be a lot of structural racisms that have led to neighborhood segregation by race and ethnicity, as well as socioeconomic status, immigration status as well, and that can shape the social and physical environment in which these patients are living in. I took this graph from one of the research papers that I felt like it was very good, large picture on what kind of factors that might play into an individual's overall sleep health. And so in the middle, you have health and well-being, and then obstructive sleep apnea as well as poor sleep health. And outside of that, you have those individual factors that could also play a role. So like mental health, as well as biology and genes, race and ethnicity, discrimination. And then beyond those individual factors, there are these family factors that can also influence sleep health. So if there's a lot of family stress, or if there's not enough resources like appropriate bedding situations, or that there's also a lot of family interactions, and it could be household chaos, and certain beliefs about sleep that can impact an individual. And then beyond these family factors, there's also the neighborhood and broader socio-cultural factors. So like neighborhood safety, or do these patients have access to green spaces or tree canopies or natural water sources? There's also light and noise that could interfere with someone's sleep health, and exposure to certain environmental toxins, and of course insurance coverage and access to care is also really important. And so the blue arrows can really just shows the interaction over time that could contribute to these sleep disparities. So I want to talk a little bit about socioeconomic status and race. So with socioeconomic status, it is used as a marker for living conditions and habits, or habitats that influence health by the different varying mechanisms resulting in accumulation of stressors. And so we have seen that low socioeconomic status, as well as having a lot of these stressors accumulate can have major implications on an individual's health-related behaviors, whether they're using healthcare, and has been shown to increase morbidity and mortality. There's been they have shown that those who have a more higher health status, meaning they have perhaps more income or have more education, these are considered as positive socioeconomic indicators and can positively influence someone's health status. And so historically, there have been a lot of minority groups that have been disproportionately living in certain areas that may have higher light pollution or noise pollution and even air pollution. Oftentimes you'll see minority groups may be living in areas that have higher crime rates and substandard housing that may or may not be amenable to temperature control. And so all of these things can impact sleep health. There was a National Health and Nutrition Examination Survey that demonstrated a higher likelihood of short sleep in non-whites and low socioeconomic status. And just to continue on with that idea, so epidemiological studies have shown that there has been consistently documented shorter sleep durations, poor sleep quality, as well as more daytime sleepiness among certain minority groups such as Black or Latinx or Asian and even Indigenous non-white people, as well as those who have low socioeconomic status. There's also this added concern that there could be racism and discrimination that can that then patients might develop something called racism-related vigilance, where it can be difficult to fall asleep or to maintain sleep because of that added vigilance. And so with the racism, there is also added psychosocial stressors. Some patients may develop trauma from these or have microaggressions toward them. And so all of these things can threaten somebody's overall sleep health. There's also residential segregation by race and ethnicity that can contribute to worsening sleep and sleep health disparities. There was a Fair Housing Act that of 1968 that was passed, where residential areas in the U.S. That was supposed to not segregate certain populations. However, despite passing this act, there still remains to be a lot of segregation. Non-white populations reside disproportionately in disadvantaged neighborhoods, and this likely has to do with historical housing policies. Oftentimes, these neighborhoods have high rates of poverty, unemployment, low college education or no college education, and may be associated with a lot of those environmental features that are just not conducive to sleep health. And so some of these environmental features that can negatively impact sleep health, one is bright lights or even loud noises, and caustic air quality, as well as with these bright lights, it can also contribute to circadian phase delay, and it even inhibit melatonin secretion, so making it more difficult for them to be able to fall asleep at the time that they are desiring. And I found this a little interesting when I was reading about this, but exposure to air pollution has been associated with sleep apnea, and it's definitely something that I haven't really considered before. But there was a study that showed that even just an increase in the annual particulate matter has been associated with a greater odds of sleep apnea, and so. Also, there tends to be higher surface temperatures in the environment of these communities that are of color, compared to more affluent white neighborhoods where if there's a lot more shade and more tree canopy, it tends to not be as hot as other communities where they may lack that type of lack the tree canopy, because it tends to increase the surface temperature. And so I know with a lot of these communities, if they're living in a house that may not have air conditioning, or where they're able to have a cool, dark environment, then it can really make a difference, having more trees in a neighborhood versus not. So, and we do know that higher temperatures can affect sleep, make it more difficult for someone to fall asleep, and it has been shown to, or at least higher temperatures have been shown that there is less REM sleep and even slow wave sleep and when sleeping in a warmer environment. And also safety can come into play. So safety actually has been shown to be one of the key determinants for healthy sleep, and even the perception of safety can really impact someone's ability to sleep. And so what they found was that resident perception of neighborhood safety and social cohesion has been associated with sleep. And so in a lot of these neighborhoods and environments, the crime rate might be high and there might be more violence, but this can negatively impact somebody's ability to sleep. Though what they notice is that there are shorter and lower quality of sleep, and then there could be prolonged wakefulness after sleep onset, and this could be due to just being more vigilant. So a sleep desert, one of the sleep deserts that I came across was homelessness. And so with the homeless population, there has been an association with poor sleep. And this could present in different ways. Could present as sleep fragmentation, or even insomnia, or have sleep restriction. So this population is particularly vulnerable, and it likely has to do with their environment. Some of these homeless people might be living on the streets, or they could be living in homeless shelters or temporary accommodations. And so if you're living on the street, there is that added stress of weather challenges and noise related complaints if they're homeless under a busy highway, or if they're in a homeless shelter. There could be extra noise in some of these shelters, and it is out of their control. Homeless people do have significant sleep difficulties in terms of overall quality and quantity of sleep duration. And so a lot of times these populations may have a lack of access to care or poor health literacy, and then they also may have other poorly controlled chronic illnesses as well. And then there's also that concern of safety in the homeless population, as some may feel that they may need to remain alert to protect themselves while they're asleep, and that can pose as a barrier. And some of they may also have comorbid other sleep disorders as well that may be difficult to treat in this population. If they have sleep apnea and they need a CPAP machine, then they may not have a reliable source of electricity, or storage of the PAP device might become an issue. And so other untreated sleep disorders can also impact sleep. Refugees is also considered a population that's that might live in a sleep desert. And so a lot of these refugees may have been forced to flee their country due to violence or from persecution. And so trauma can become a big concern for refugees. And there has been systemic reviews on sleep health among refugees that showed that chronic insomnia is highly prevalent, and it can range anywhere between 32.6 to 73.3%, depending on a definition of insomnia or the screening tools that was used during this systemic review. There was a paper that showed that there was a group of like 40 adolescent refugees from 10 different countries living in Germany that showed a correlation between PTSD, anxiety, and prolonged sleep latencies and shorter sleep durations. PTSD and remains one of the most associated disorders with disturbed sleep among refugees. And on top of that, there may be additional stressors and barriers, including lack of access to healthcare specialists. There could be language barriers, and then as well as racial biases. A prison environment could also be a sleep desert. These prisons tend to be highly controlled environments, and can contribute to lower sleep quality and overall sleep disparities. Oftentimes in high security prisons, there may be 24/7 lights on for continued monitoring, and there are these necessary inmate counts that occur during sleep hours that can disrupt sleep. Within the prison, there may not be adequate bedding as well, or the bedding is very thin and uncomfortable. Noise levels can be high in prisons, and then there's also forced schedules that can make it difficult for overall sleep health. And so there was a study done on incarcerated women that reported that sleep quality, which was measured by PSQI, related that both perception of safety and the prison environment reported overall poor sleep quality. from perception of safety and the environment. And so there's also an increased risk of psychosocial stress. Some of these inmates might have nightmares or a lot of ruminating thoughts, and so a lot of like chronic medical conditions and environmental disturbances have been predictors of poor sleep among these incarcerated individuals. The perception of poor sleep, too, has also been associated with higher risk of perpetuated aggression in some of these inmates. And as we know, having insufficient sleep can affect our behaviors. It may manifest as aggression. Okay, another sleep desert is college students. And so I'm sure a lot of us are familiar that many college students might be sleep deprived. There is a lot of, there could be a lot of unhealthy lifestyles and academic and social pressures that could drive these college students for sleep deprivation and poor sleep behaviors. And so, and I mean, and a lot of these poor sleep behaviors can include things like having an irregular sleep-wake schedule. I'm sure you've heard of the terminology of pulling an all-nighter to study for a test the next day. There's also caffeine could be involved in energy drinks, and then stimulant use as well. And then there's alcohol and recreational substances that college students might be exposed to. And all of these things can interfere with sleep. Also, technology use. I'm sure a lot of students are using their laptop to study for exams in the wee hours of the night. And so that, coupled with how adolescents physiologically tend to have a more delayed circadian preference. You couple the light exposure and that delayed circadian pattern, and so it can be a recipe for poor sleep health. Other populations that we could consider for this are hospitals. So when patients are admitted, oftentimes they do have nocturnal care. And so they'll have vital sign checks at night. They might have IV fluid changes as well as scheduled medication administration. And so this can disrupt their sleep. There was a systemic review and a meta-analysis found that that sleep duration was 1 to 4 hours shortened in hospitalized patients when compared to home. And so this really points to how sleep quantity and quality are insufficient in hospitalized patients. So they are at risk. Also, reproductive life or women's health. So women can also be vulnerable to sleep insecurity, especially during certain key stages of reproductive life. And so pregnancy has been associated with compromise in variable maternal sleep along the 3 trimesters. Even the postpartum period, both the mother and the father, their sleep really depends on the feeding schedule of their infant. And so that sets up an environment of insufficient sleep. Even perimenopausal women may experience acute insomnia symptoms, and that may reduce their overall quality of life. Postgraduate medical trainees are also at risk. Even despite having duty hour regulations, a lot of trainees remain to be significantly sleep deprived and have consequences of insufficient sleep. Interns performing extended overnight shifts have been shown to have moderate chronic sleep restriction and a significantly reduced alertness level after on-call night shifts. Okay, so in summary, I did, so just to kind of wrap this up, the key points is that for adults, minimum sleep requirements is 7 hours. And if you're chronically not getting enough of these hours of sleep, it has negative impacts on your overall health, cardiovascular, metabolism, behavior, neurocognition, all can be affected. And these sleep deserts refers to how these neighborhoods or certain populations that are at risk for sleep insufficiency due to external factors. We see this mostly in these economically disadvantaged neighborhoods and low socioeconomic status. And so some of these vulnerable populations we just touched on were the refugees, the prisoners and homeless, college students, and post-medical graduate or post-medical trainees. But this list is definitely not all inclusive. And so I wanted to kind of raise awareness on this topic because it's not very well talked about. I didn't even know what a sleep desert was until I did my research on it. And a lot of factors can play a role in what went in somebody's overall sleep health. So I really just kind of wanted to raise that awareness the next time if you do or have ever worked with underserved populations or economically disadvantaged individuals, that I hope that you can see kind of where the patient might be coming from and how that might be influencing their overall sleep health. Any questions?
That was great. Thank you, Suzanne. Such an important topic. I was wondering if you came across any suggestions or even, in your own experience about how we on a local level as clinicians can address some of these factors that influence sleep, even if we can't, influence all of the determinants.
Yes, so there were some articles on how we can improve, and I wish I did include, because I found a really good chart on this. If you don't mind, I can try to find it and share my screen because it did really encompass some ideas. So give me just a second, I can show it to you. But some of it did involve like having social work get involved and plugging certain underserved populations into certain resources, but then it also involved kind of on the city level on like how to address like certain housing policies and things like that to kind of help get these patients out of these neighborhoods that are just not conducive to sleep. But give me 1 second. I'm just going to stop sharing my screen. But I can ask, and I'll come back to you, Dr. Salazar. I'm going to show you this chart because it was very helpful.
Great, thanks.
But I can answer any other questions in the meantime while I get this chart up.
I had a question / comment that's building on hopefully what you'll show us. Can you hear me? This is Deirdre.
Oh, hi.
Hi, I had, last Wednesday, I had a 37-year-old African-American male referred to me for insufficient sleep. And his situation was he worked on the line at Ford until 1 in the morning, got home around 2 in the morning, and then had to take his daughter to school at 6 in the morning. You know, we had a conversation highlighting a lot of the consequences that you raised today, but as a provider, I did feel like stuck, and I wish that there was something else I could sort of do. I understand there's a conversation about them and their schedule, but any other resources that we could help them with, or you mentioned social work, or
Yeah,
advocacy from sleep medicine or National Sleep Foundation. I don't know. I just felt stuck. So I didn't know if anyone else had similar experiences.
But yeah, thank you for bringing that up. And that is a very interesting point, because oftentimes, even with these underserved populations, we do try our best to provide the care that they need. And at the end of the day, there is a lot of external factors that are out of our control and the patient's control as well that can influence this.
Well, I don't remember so well the last time I saw somebody quite like what Deirdre is talking about. I'm sure I have, but I will say I do remember, you know, I haven't been a lot. No one of us has been often to Hope Clinic, but many of us have been there several times. And I've already encountered, I don't know, at least 2, but not more than 4 patients who used to be patients here and no longer have access to our sleep center because their insurance, they lost their insurance or something, and that's been a sobering thing. I don't know if Galit wants to say something about it. She's been having maybe a better overview of the whole thing.
Nothing to add other than this is why we're doing it, right? We want to provide access to people who are challenged. But, you know, having access to sleep medicine doesn't mean we can remove them from the sleep desert, right? They can still live in the sleep desert,
Okay.
but maybe have some strategies to better deal with it, right?
Yeah. Okay, so let me share this. I found the chart on some possible interventions. Okay, so I don't know if you can see here. So as far as, so there's different ways to go up, at least this is what is proposed on this one specific paper, but advocacy is one of them. So I know advocacy as far as like access to care, and then a lot of this though is like urban planning. So like, and this is something that I mean, we as providers are unable to do on like an individual level, but like certain things like improving the environment that they live in, like access to more green spaces, having more walkability, and then the noise pollution and air pollution is try to reduce that. Optimizing neighborhood safety, again, like that would be difficult from our end to do. Education against anti-racism and medical training. And then of course there's to address like beliefs about sleep and health literacy, education in the clinics, even in the daycare and school level, or even social media, using like mobile apps to promote the healthy sleep. And then for discrimination, integrated cultural appropriateness with impairment. So it is a difficult to resolve these things. So it was a very good question, Dr. Shagakar. But yeah, on an individual level, it might be hard to do some of these things.
Great, thanks for sharing this table.
Well, I have a question for the whole group. And I don't know if there was anything in your research, Susan. But who thinks, and I'm going to switch my screen so I could see everybody, but put your hand up. I have 3 questions on your reaction there, and put your hand up, or else turn your camera and put your hand up. If you think that food is a basic human right. Okay, so we have 20 people, and I see 1, 2, 3, 4, 5, 6. Okay, so not most people.
I want to put my hand up, but I don't know how to do the hand on
Okay.
this, but my hand's up.
All right.
I just
So
added
let's see.
mine.
All right. So look, it's an important question. So all right, about half of us think that food is a human right now. Okay, and Enrique is adding. So how many think that clean air, breathable air is a human right?
Yes, I think so as well.
All right, I thought these would be more popular than I'm seeing, but maybe some people just have trouble raising their hand. I want to compare that now to who thinks that sleep is a basic human right.
I think so. Yeah, absolutely.
Okay, so we lost only let's see how many. I'm interested in how many we lost with the question. Oh, we didn't lose anybody really, because we have 12 saying yes, and Enrique. So it's an interesting thing, because most people, I'm not sure that it comes to the tip of their tongue if you just walk to somebody on the street and say, "Do you think sleep is a basic human right?" But there's a growing literature on that, and some organizations have come up to the plate and said that it is. And the only reason I know that is because we were asked, and when I say we, Galit and Erica Jensen and I were asked to write something about this topic of sleep inequities, and what to do about what should be done about it from a public health perspective. And so we found some of this literature. So I think there's a growing recognition that sleep should be a basic human right, but I think it probably needs to grow more and be recognized by large American professional associations still. And then the question of what to do about it, I'd be interested if people have ideas. I can tell you, or Galit can tell you what we said in that piece that we wrote. But what should be the top public health priority to address sleep deserts and sleep inequities? That's realistic too, because obviously, if I had half the budget of the U.S. Government at hand, all I could do. But
I mean, I don't know about rank ordering them, but it seems to me that housing is a big component of this, right? And so I think there's a lot of structural racism that has influenced housing policy in this country over decades and centuries. And I think that plays out also in these sleep deserts that Suzanne presented. So I think these things are very tightly intertwined. So if money was no object, I think that would be a big place to start.
it's a good point. Any other ideas? I'm interested if anyone's going to come up with what we came up with for that article. Maybe not. All right. Well, look, since the time is getting short, I'll just say, unless Galit, you want to say? The main point was that we thought education was low-lying fruit, low-lying fruit. Because we
Mm.
felt that still that the sleep education is one of those inequities. And that people don't know the importance of getting a good night's sleep, and that there might be a lot of progress made short of, uh, redirecting substantial portion of world budgets. We thought that education could probably be provided through starting at early ages in school, all through schools, with adult education opportunities as well, just so that people know that sleep is important, just like, our Grand Rounds today emphasized for the first part of it.
Sorry,
But-
Ron, I started to talk and I was muted.
Oh, go ahead.
I just wanted to say, I just wanted to say that we talked about individual awareness, awareness on the individual level, but also on the societal level.
Yeah, that's right. More. It is a
And-
big program. That was a great Grand Rounds to cover.
Thank
And
you so
sorry, before everybody goes, if anyone is interested, I can't resist. We need another physician for the sleep clinic in July 20. We have one physician, but we need another one. If anyone is interested, please let me know.
Well, great job again, Suzanne. I don't see any other questions in the chat, so kudos. That was fantastic.
Thank you so much. And thanks for coming to my Grand Rounds.
Thank you for giving.
Thank you.
Thank you.